Hello and welcome. My name is Guy Bogaert. I am a pediatric urologist in Leuven in Belgium. And I'm happy to actually host this video podcast on the new spinal dysraphism guidelines. And actually, I'm very happy to introduce to you today a good friend and colleague, Christian Radmayr, who is a pediatric urologist in Innsbruck. But more specifically, Christian, you are actually our chairman for, I think, a little bit more than 7 years of the Paediatric Urology Guidelines. So actually for this update on spinal dysraphism guidelines, you have chosen a completely different way of approach of updating these guidelines. Can you tell us about it?
Yes, sure. Thank you very much for the introduction. Well, I thought that spina bifida would be an ideal topic to go a new way for guidelines development, because spina bifida is a rather complex condition and it's affecting multiple organ systems, of course, including the urinary tract and the kidneys, but not only. And historically, there has been significant variation in how urological management is approached. And that led to inconsistent patient outcomes, which is not good. So our goal was to develop an evidence-based guideline that standardizes best practices, ensuring that children and adolescents with that conditions really receive high quality and coordinated care, and regardless of where they are treated. And additionally, by incorporating input from various stakeholders, meaning various medical disciplines and patient representatives, we aim to create a guideline that is truly reflecting the needs of both the healthcare providers on the one hand and the affected families on the other hand.
Okay, that's very interesting. So have your inspiration of bringing all those groups together from what we know from clinical practice, the multidisciplinary spina bifida clinic, and actually where all different experts are together and the patient with the family are actually the central part of the treatment and approach.
Yes, absolutely. In most centers, spina bifida patients are taken care of by a multidisciplinary team. And we incorporated that in our guidelines development process. And in addition to that, we also asked for participation of methodologists, which is very important because they ensure that guidelines are evidence-based. That's the one thing. And they are using rigorous research protocols and methodologies and grading systems. And what happened for the first time, we incorporated in our team from the very, very beginning onward patient representatives. And that was new because they really do provide first-hand perspectives on the challenges faced by children with spina bifida and their families. So it was not only the medical specialists like us as pediatric urologists, pediatric nephrologists, psychiatrists and psychologists, but also some other teams which are usually not around during a multidisciplinary spina bifida clinic.
Okay, so how did you choose your specialists? Were they experts as of that you know them from the literature? Or are they key opinion leaders, or maybe both? So how did you select your different stakeholders?
Well, from the medical specialists' point of view, it were mainly experts that in that specific field of spina bifida. But on the other hand, when it comes to patient representatives, of course, these are stakeholders that are nowadays in this modern area of social media sort of influencers. They are a voice to the public. They are very, very important because they bring in their everyday perspectives, but they also ensure that what we are building up in that guidelines is disseminated. So that there was a sort of a mixture between experts on the one hand and sort of influencers and patient representatives on the other hand.
So your approach, like you are used to do that in the classical update of the EAU, ESPU guidelines, is, looking for evidence-based papers, good studies, good articles. Was that similar now?
Absolutely. So when it comes to do the updates, we followed strictly the validated methodology that is built up by the EAU Guidelines Office Methods Committee.
Okay.
And all participating parties agreed to follow strictly that methodology, because that is very, very important, because at the end, we want to come up with recommendations, and we need to underpin the strength of recommendations by evidence. So that was very important that all participating parties stick to that methodology.
So with all those different specialties, did you encounter any new challenges?
Well, indeed, it was an interesting endeavor, I must say, because one of the main challenges was to integrate the diverse viewpoints. On the one hand, and on the other hand, we had to maintain a clear and actionable set of recommendations. So that was not that easy. For example, to explain this maybe, while we as pediatric urologists and also the nephrologists really agree on we have to do everything to preserve kidney function, that's why we do recommend soon after birth intermittent catheterization. For us, this is clear. But on the other hand, at the same time, the psychologists or psychiatrists, they emphasize that by recommending that, this is a huge emotional burden of lifelong catheterization. For example, this is a complete new and different and diverse view on the same topic. But the good thing is, at the same time on the table, we had the patient representatives. And the patient representatives, they can bring in what it means in everyday life. So this is sort of having incorporated real-world data then in our final recommendation. So to resolve all those challenges, we had structured discussions, quite a lot of them, and we reviewed patient outcome data, and it was important to ensure that all the decisions that we made are prioritized by both medical efficiency on the one hand, but also patient quality of life.
Yeah, Christian, I love that actually example that you gave, that I think the psychologists and psychiatrists, they mean it well to say, oh, the poor little children and the poor parents needing to perform the intermittent catheterization. Whereas those parents and children, they say, well, intermittent catheterization, it's like brushing our teeth every day.
Yes.
And they don't mind. And actually, that is, I love this example of how I think with your new guidelines, or let's say our new guidelines update, we will probably improve the clinical application of them in daily life. Don't you think so?
Yes, absolutely. I hope that this will be indeed a way how we can overcome that problems, and that is implementation. Because we always have to think of our sort of target audience. Who are the people we are making that guidelines? Who are the affected patients? And what is a recommendation worth if that recommendation doesn't meet everyday needs of life? So that's one of the things that challenges we are faced with. And by integrating all those diverse stakeholders, it should be possible to help implement it.
I think also, do you think by incorporating all those specialties, is it one of your strategy also that they will also in their scientific society will promote our common goals and our common guidelines? Is that one of your goals?
Absolutely, because our guidelines now really established a unified framework, and that can be used by different healthcare providers across the specialties. And this is one of the big advantages. That means that the nephrologist, urologist, and even the psychologist do treat the same patient, and they will be following the same evidence-based principles. And that is one of the big advantages. And that will reduce the discrepancies in treatment approaches that we have. And that sort of standardization helps to improve the communication between all the specialists and also ensures that the aspects of care are really addressed in a coordinated manner.
Okay, so the updates or the update from these guidelines is mainly focused on the new evidence from the past 4 years?
Absolutely. We did a complete search of the literature because the previous update was done 4 years ago. So we searched the literature for that period of time. And in addition to that, we searched the literature for much, much longer for new topics that we included in our guideline now, such as sexuality and fertility. 2 important topics to be included in a spina bifida guideline for children and adolescents, for example. And the same is true for topics like health-related quality of life, or for topics like psychological disorders and problems within the affected families, because this is completely new now in the guideline and has never been addressed before.
Okay, thank you very much for bringing those 2 examples already. Did you have, besides the, let's say, early a recommendation of very early start of intermittent catheterization, did you have any other examples of conflicting views? And how did you, as the chairman, as the boss, how did you resolve them?
Well, definitively. I mean, there are so many different views when you have such a group of diverse stakeholders sitting on a table discussing the same topics. But on the other hand, we finally came up with recommendations really regarding early urological interventions where we were able to find an agreement because we all have the same goal, and that is to prevent long-term kidney damage, especially for that patient group. And in addition to that, we also now included a more structured approach to transition, because that is something that has never been addressed before. And transition of adolescents into adult care really is an area of concern, especially for us as pediatric urologists. When we later on are handing over those patients, we would love to take care of a proper transition because that's so important. And on the other hand, some outdated practices that are there, such as the routine use of prophylactic antibiotics for UTIs, for example, have never been reconsidered based on that new evidence that is there. So these are just some of the examples where it was very, very important to have all these diverse people on the table and talking about it.
Okay, so yeah, I like that idea as well. Like, okay, why do you give antibiotics? Because we've always been doing that, and we've given those children antibiotics for already 20 years. So that must have been based on good evidence studies. Did you encounter some gap or lack on good evidence-based studies? And which ones?
Definitely, because as it is true for most of the pediatric urology guidelines, which is covering really a big field, it's the same for spina bifida. There is the lack of high-quality randomized controls trials. And that's true for almost all fields in pediatric urology, and especially for spina bifida. So much of the existing research was based on observational studies and expert opinions. And one of the biggest gaps is definitively long-term outcome data. Long-term outcome data of different management strategies. For example, we in our guidelines, we are proposing the active approach, meaning starting CIC and anticholinergics very, very early on in life. But on the other hand, we know that intermittent catheterization is indeed widely used, but we have long-term data lacking on how that is affecting, for example, bladder function over decades. So that's the big problem. We do not know what happens if a bladder is catheterized 5 or 6 times a day and what happens after 50 years, for example. On the other hand, the same is true for the psychological impact of different treatment modalities, because that is under-researched as well. So there are still a lot of gaps and cases where the data are insufficient. So that means that in many cases, we have to rely on expert consensus and hope that ongoing clinical experience and real-world data will help to overcome these gaps in the future.
Yeah, I hope so that we will also inspire our listeners and viewers to start these studies that we really need to actually base and support the statements that we give in our EAU, ESPU guidelines for pediatric urology. Did you check these guidelines that are now published and open and for everybody? Did you check them that they will be able to be implemented?
Yeah,
maybe worldwide?
Implementation is definitely a big issue and a big problem in many countries. That's for sure. So that was the reason why we tried to design the guideline with a lot of flexibility in mind, ensuring that it could be adapted to different healthcare systems. So we included both essential recommendations on the one hand, and on the other hand, also some optional strategies that can be tailored then to best available resources. Because this was one of the things we were very much interested in, to help implementation in different healthcare settings.
Okay. If you would have a wish how we could spread the word about these new guidelines, or not new, but maybe very good guidelines that actually are accepted by so many specialties now. How can we support you to spread the word wherever in the world?
Yeah, I think that to maximize the adoption, partnering with medical societies and professional organization is important to integrate that guideline into clinical training and continuing medical educational programs. So it's important that after finishing the whole process of guideline development, that we are now active in dissemination. And propagating the guidelines. So we need online learning modules, webinars, workshops, and so on to familiarize clinicians with our recommendations. And of course, publication is one thing, but I think nowadays using all the various social media channels that are around and all the influencers and various stakeholders is so important to help disseminating these new guidelines.
Okay, so Christian, maybe we should actually end and summarize a little bit to say, okay, you have, I think, together with your group, set a milestone for these guidelines for spina bifida neurogenic bladder in children. So when could we expect your next update? How are you going to do? Are you going to do the same procedure, the same methodology? And when can we expect that?
I think it's very important that you take care of a structured update process, because now the guideline is there, but that is not the end of the work. That's the start of the work almost, because a structured update process is important. That means periodic literature reviews, expert panel discussions, and so on. And as soon as any new important trials emerge, we have to have a look at those data, and if they are really of good quality, include that in a guidelines update. So that means that we are planning to have at least every 4 years a complete revision and update process. And of course, that is also then following the validated methodology given by the EAU Methods Committee. That's important.
Okay, well, I think we can close here, and we thank you for your attention. Please stay tuned for the next update of the EAU ESPU guidelines on pediatric urology.